I have been in those situations a long, long time ago when I was in Vietnam. The answer is you shouldn't.
Thank you.
You shouldn't fall into that trap.
Thank you.
But don't misunderstand my answer. I am sympathetic to those emotions. There's somebody that's donated blood and you're not going to use it. And so it raises an uncomfortable feeling. But one should be very strict about what blood they give, and if you have to throw away blood, so be it, although that's painful to do.
Thank you, sir.
Yeah, Dr. Bande.
Dr. Bande from Pune. With your lecture, I thought there was emphasis on liberal transfusions. We are trying to follow our trigger at 8 gram %.
You're saying my emphasis is on liberal transfusion?
I saw the tendency going towards liberal transfusions.
No,
sorry.
No.
Okay.
Mine is be careful about getting too restrictive.
Yes, thank you.
But
we are trying to.
I'm interrupting you. Please don't walk out of here and say I'm in favor of liberal transfusions.
Yeah.
That is not true. I'm very careful though about the direction and how far do you go with the restrictive one. I'm a little bit worried, and I do that with everything.
Okay.
When we have mass action going in one direction, I sort of say, well, wait a minute.
My question was relevant to that, and as 8 grams trigger, we are trying to follow it as much possible, where we always fight with surgical colleagues, especially gynec colleagues, that they want to give transfusions preoperatively without following this. Now with increase in safety, as you are saying, now we are better on the tests. Is this trigger going to get shifted towards higher value of hemoglobin in near future? That is my question.
I'm not sure I understood your question, but there's no question that patients who have preoperative anemia, I do believe that, are at higher risk for morbidity and mortality. And so in some way or another that should be treated.
Thank you.
At least that's what the data shows.
We have the last question of this session. I allow this lady.
Morning, sir. My name is Dr. Bhargav. I'm from UK. It was an honor and a pleasure to listen to you.
I should say that some of the articles I've been talking about appeared in UK journals.
And it was a good point that you had made that all these guidelines are for those patients who are not bleeding. My question is, in your clinical practice, do you try to chase number of 8 when a patient is bleeding, even if the patient is ASA1?
The hemoglobin by itself is only part of the decision. And if I'm not sure about a hemoglobin of 8, that's pushing me a little bit in a healthy patient. That's really, I think I probably, if the patient was fairly healthy, didn't have coronary artery disease, I don't want to give a strict formula like I heard from the previous speaker, but just to extrapolate, I'd be, if a patient was healthy, pretty healthy, had good cardiovascular status, my finger would be on the trigger, but I wouldn't press the trigger unless I saw more bleeding, I think.
Thank you very much.
But if a patient is actively bleeding, if they're hypovolemic and the hemoglobin is 8, you don't really know where, even if they stop the bleeding, you don't know where that hemoglobin's going. Because if you start giving a lot of crystalloid, the hemoglobin might be lower.
Yeah.
And that's getting into an area where I think it's documented that post-op patients shouldn't be. So that's a tough question.
Thank you very much.
Thank you. We come to the end of this session, and I want all the audience to give a big hand of applause for it.